Dark night. In a distant future, a dystopian world grapples with the threats to human existence.
Underground? Well, the sewers do seem like an apt post-apocalyptic setting. But before we get too far ahead of ourselves and dive headfirst into a manhole with a cover that says septic, let's talk about what sepsis actually is. Though in flux for decades, since 2016, and including the most recent October 2021 guidelines update, sepsis is defined as life-threatening organ dysfunction due to a dysregulated host response to an infection. Whew. That was a mouthful. Let's break it down. See these microbial-shaped lanterns? They're here to shed light on the fact that we need a documented infection to call a patient septic. Bacteria are the most common offenders, but even fungi and viruses can cause sepsis. These lanterns also seem to be leading us deeper into these creepy sewers, just like infection leads to the next part of sepsis. Severe infection causes the normally balanced inflammatory response to run out of control. Pro-inflammatory cytokines and cellular mediators are released systemically, causing vascular dilation, capillary leakage, and fluid shifting into the interstitium. Significant vascular dilation and volume depletion result in intravascular hypotension, which leads to tissue ischemia, cellular injury, and ultimately organ dysfunction, the second part of our sepsis definition. Just like this dysfunctional organ is out of order. Looks like they took it apart to get it down the shaft and had a little difficulty putting it back together. Silly dystopians. To determine whether organ dysfunction is present and how severe it is, a number of scoring systems exist. The most common is the Sequential Organ Failure Assessment, or SOFA, hence this conveniently placed sofa for playing the organ. Note that this is not to diagnose sepsis. It's only used to determine the presence of organ dysfunction. Ah, of course, there's more than meets the eye down here, and this bartender clearly has a few stories to share. Nice tattoo, dude. Well, once sepsis is bad enough to cause circulatory, cellular, and metabolic derangements that raise mortality risk, we can now say the patient is in septic shock. But that's not really clinically useful. So, based on the most recent guidelines, shock is when, despite adequate fluid resuscitation, hypotension requires vasopressors to keep the MAP, or mean arterial pressure, above 65, and lactate is elevated over 2. Lactate is used here as a marker of tissue hypoxia, since it's a byproduct of anaerobic metabolism. Our recurring symbol for lactate is spoiled milk. I guess you gotta make do with what you have in post-apocalyptica. See how our bartender is pouring it from an elevated position? One of those fancy bar pours? And you can remember vasopressors with this citrus pressor, or squeezer, like we're giving the vessels more squeeze. Alright, so we've been talking about the newest sepsis definitions, but the old ones are still commonly taught and used, so it's worth going through these now as well. Pretty sure birds in a cage are not up to restaurant code, even if this septic sewer were a coal mine and those doves were canaries. Oh, dystopian future. Nevertheless, this establishment is not without some decorum. Take this sir here. Not only is he the maître d', he's also our symbol for SIRS, or Systemic Inflammatory Response Syndrome. It's just like it sounds, a syndrome of systemic inflammation, and is defined as having 2 or more of a temperature over 38 degrees Celsius or under 36, leukocytosis over 12 or under 4, tachycardia over 90 or tachypnea over 20. Clearly, our maître d' is a stickler for on-time reservations. Quelle heure est-il indeed, monsieur? A documented infection and SIRS is considered sepsis by the old definition. Sepsis plus organ dysfunction gives you severe sepsis, a term that isn't used in the new guidelines because it's too vague, and where there's sepsis, organ dysfunction, and hypotension, it's septic shock. Okay, with all that in the past, let's talk about these patients. These people are sick, but their reported symptoms can be very vague. Maybe some fevers, chills, rigors, malaise, and fatigue, but overall, they just feel like absolute garbage. Kind of like waking up after a bender in a post-apocalyptic bar. Like this gal, but even worse. They may also have symptoms related to the specific infection that's causing their sepsis, so don't skip that review of symptoms. We're not going to go through all of them here, but Think in terms of a productive cough for pneumonia, or urinary frequency, urgency, and pain for a urinary tract infection. Importantly, anyone with an infection can progress to sepsis, but patients who present sicker or who have multiple comorbidities are more likely to die. So, keep an eye out for risk factors like advanced age, immunosuppression, recent surgery or hospitalization, or conditions like diabetes. Vital signs for these patients will reflect how sick they are. Most of these signs we covered when we mentioned SIRS: tachycardia, tachypnea, fever, or hypothermia, demonstrated by our fancy Sir and his fashionable accessories, and hypotension for those in or heading into shock. Keep in mind that septic shock is a distributive shock with a markedly reduced systemic vascular resistance, referenced by these very loose, untied shoelaces, our symbol for low SVR. And it's a warm shock, meaning the patient's skin feels warm, as opposed to cardiogenic or hypovolemic shock, which are cold types of shock with cold and clammy skin. But late in septic shock, extremities will start feeling cold and clammy. And it's as bad as it sounds because peripheral vessels are constricting to shunt blood to vital organs. Hot coffee and ice water. Bartender's doing anything to get this guy back on his feet once he wakes up. These skin findings lead us right into the physical exam findings for sepsis. Exam findings for sepsis follow the theme. They're generally vague and non-specific. Altered mental status is common, symbolized by our recurring falling brain hat. And the slow from this kidney-shaped bottle should remind you of the drip, drip, drip that your patient's urine will be doing, as in they'll have reduced urine output since they're so volume depleted. You might also notice other indications of volume depletion, like dry mucous membranes and poor skin turgor. Apart from those, you may not see a whole lot that's specific for sepsis, but remember to look for exam findings that point you towards the source of infection. Wet crackles and rails for pneumonia, spreading erythema and purulence from a wound, that sort of stuff. But even those can be absent, depending on the patient, like a diabetic patient with an infected ulcer who can't mount a proper local or systemic immune response. With these vague findings, we need more information, so let's go get some labs. We already talked about leukocytosis over 12, or leukopenia less than 4. Lactate we mentioned already as well, representing the anaerobic metabolism of oxygen-deprived tissues, and this excess lactate leads to lactic acidosis. In fact, sepsis is a major cause of lactic acidosis, a type of high anion gap metabolic acidosis. Think of these acidic lemons to help you get to metabolic acidosis. But keep in mind, it's not the only acid-based disturbance these patients can have. Hyperventilation due to pneumonia can lead to respiratory alkalosis, or a mixed metabolic and respiratory acidosis from respiratory fatigue and failure. And with all that hypotension, the kidneys are going to take a hit too, specifically a prerenal acute kidney injury, symbolized by this cracked kidney bottle. Look for a high creatinine and that decreased urine output we mentioned earlier as well. Other helpful labs include acute phase reactants like elevated platelets, procalcitonin and CRP, coagulation studies for DIC, bilirubin for liver damage, hyperglycemia as tissues can't utilize it. I could go on and on about the labs in sepsis. They're generally non-specific, and changes can be associated with the underlying infection itself, tissue hypoperfusion, or organ dysfunction. Point is, in sepsis, labs reflect how sick your patient is. So yeah, there's a lot going on in sepsis, but don't forget, we also have to identify and document the source of the infection. Culture everything that's appropriate, like blood, sputum, CSF, the wound, urine, joint aspiration, anything that can find you that infection. Anything including moldy bar snacks. Okay, maybe not those. Imaging helps with this as well, like chest x-ray for possible pneumonia, CT scans for abdominal or pelvic sources. So slide that patient into the photo booth or the lead-shielded CT scan room, either one. Once you know your patient has sepsis, you've got to treat them immediately. As with every sick patient, start with the ABCs and secure that airway if needed. Of course, in the hospital, we use airway breathing circulation. Not too far off from the motto in this joint. After the ABCs, there's two major goals in sepsis management: restore tissue perfusion and control the infection. Restoring perfusion is C for circulation. These patients are massively volume depleted, so fill their tanks back up. And they're going to need a lot. 30 cc per kilogram of crystalloid and boluses of 500 at a time is the best thing to do, given within the first 3 hours. But be sure to watch for over-resuscitation and fluid overload, especially in your elderly and comorbid patients, particularly looking for pulmonary edema and hypoxia. Those cucumbers are a bit fancy for a dystopian future. Maybe hydroponically grown? But don't attribute every worsening respiratory status to fluid overload. Sepsis is a major cause of ARDS. We're not going to get into ARDS stuff here, but you don't want your patient to go there. Just like you don't want to walk past Big Mouth Billy Big Shark here. It starts playing Baby Shark ad nauseum. If patients do start developing fluid overload or aren't responding to fluid appropriately, then it's time for the big guns. And by that, I mean vasopressors, to keep their blood pressure up and their organs perfused. Norepinephrine is preferred for first line, and we've already symbolized vasopressors with our citrus pressor here. And with that, we've hopefully restored perfusion. Our second goal is handling the infection. This is done with broad-spectrum antibiotics within 1 hour of presentation. Get that bug juice in there even if you don't know what bug it is just yet. Which reminds me, it's best to get cultures before starting antibiotics. But antibiotics should not be delayed, particularly in the very sickest of patients. Once culture results are back, you can tailor the antibiotics to the specific offending microbes. This pill bottle full of, mints should remind you of antibiotics. And they have a broad spectrum of color, kind of like how the antibiotics should be broad spectrum. Keep in mind that with certain infections, all the antibiotics in the world won't fix your patient. So that's where source control comes in. Get rid of the source of infection wherever possible. Abscess? Drain it. Perforated appendix? Surgery. Empyema? Chest tube. Empanada? Microwave. Get that infection out of there in whatever manner is best and fastest. It's lights out for the infection. Just like this big ol' switch means lights out for our microbial lanterns. Ooh, so tempted to pull it. But first, let's review. Sepsis is defined as a dysregulated immune response to infection that leads to organ dysfunction. Patients are sick, generally with tachycardia, tachypnea, and either fever or hypothermia. If they're in septic shock, they're hypotensive as well, due to reduced systemic vascular resistance. Signs and symptoms of sepsis are vague, with fevers, chills, rigors, altered mental status, and signs of volume depletion. Labs reflect the significant illness of the patient, with leukocytosis or leukopenia, an elevated lactate and metabolic acidosis, acute kidney injury, and many other cellular and metabolic derangements reflecting the source of infection, tissue hypoperfusion, and organ dysfunction. Be sure to look for signs and symptoms for the source of infection. Imaging and cultures will help identify the source of infection as well. Treatment revolves around two goals: restoring perfusion by fluid resuscitation first, and only vasopressors once they fail to respond to fluid or become fluid overloaded, and infection management with broad-spectrum antibiotics given within the first hour, and source control to remove any infection as possible. All right, I'm going to do it. I'm going to throw the switch. Now it's lights out for real. Oh. Wait a second. So it's not a post-apocalyptic world? It just looks like Brooklyn circa 2014? Or Cleveland now? And the bar is just another hipster speakeasy. Antiques, caged doves, and overpriced spoiled milk? I think I'll have what he's drinking.